Good morning, and thank you for joining us for today's Facebook Live discussion with Dr. John Clohisy, a nationally renowned hip specialist. Good morning, Dr. Clohisy.
Good morning, Crystal. Great to be here. Thanks for the opportunity to talk to you this morning.
Great, thank you. Let's go ahead and get started at the beginning. We all know that as we get older, things stop working the way they used to. Back starts to ache, knees become sore, and hips become stiff and painful. When is it time to see a specialist?
So, Crystal, with hip pain or hip problems, patients can present at different ages. Like you said, as we age, certainly we see patients that get stiffness and pain in the hip, and certainly that's a time when we want to evaluate the hip. But we also see younger patients that have hip pain, and if those symptoms are persistent, we'd like to evaluate those patients as well. So I think in general, so first, really important is kind of understanding hip pain. And one thing that a lot of patients don't understand is that hip pain is usually in the groin, in the front of the hip, deep groin pain. That's really true hip pain. So if you have pain in that area of the body, then we do think about the true hip joint. There are also other pains about the hip on the outside of the hip or the buttock in the back of the hip or associated pains in the low back that a lot of patients think about as hip pain. But true hip pain is really in the groin area, in the front of the hip or the deep groin. In terms of seeing a specialist, I think in general, we all have episodes where a joint or part of an extremity can be sore or stiff, or we could have a muscle strain or something like that. Those less severe pains can be treated with rest, icing, anti-inflammatory medicines. But if pains like that persist beyond 6 weeks, I think it's a good time to start to think about seeing a physician. A lot of patients prefer to see their primary care doctor first, and that provider may start additional non-operative treatments. I think when pain or discomforts persist out to 3 months, then we really have to start thinking about seeing a specialist and considering all the different options of treatment. And again, important to break hip conditions down kind of into two patient populations. We have the older patient, and for us in general, that means patients over 50, where we start to think more about arthritis of the hip. And the most common symptoms with those patients are pain in the groin, stiffness, limitations of activity, that kind of thing. And then in the younger patient population, really patients starting in their early to mid-teens up to the age of 50, that's more the young adult population. And in those patients, they tend to, again, have groin pain, but it tends to be more activity related and associated with exercise or sport activities. So those are the two groups that we're going to talk about today. But I think a general rule, 6 weeks of symptoms, we want to get that checked out. And in 3 months of persistent symptoms, we think about seeing a specialist.
Okay. Yes, so here today, we are specifically going to talk about hip replacement versus hip preservation. What is hip preservation in comparison to hip replacement? And is it one single procedure?
Yeah, so that's a great question, and a question that a lot of patients don't fully understand. So traditionally with hip surgery, we've talked mostly about, over the past several decades, hip replacement. And hip replacement is a procedure where the hip has end-stage arthritis of the hip, and we actually replace the natural hip joint with a prosthesis. So we have an artificial socket, a metal socket that's placed in the pelvis that has a plastic lining or polyethylene lining. And then we have a stem, a metal stem that is placed down the shaft of the femur bone, and that has a prosthetic ball on it. So that's a true prosthesis or a hip replacement. And again, that's a very common procedure that's usually performed in patients over 50 years of age. And you hear a lot about different types of hip replacement. And we've been focused on that type of surgery for over 20 years and really have developed a very strong program in hip replacement. On the other hand, we have hip preservation. So hip preservation are procedures where the natural hip joint is preserved. So we're not replacing the joint, but we're refining or modifying the natural hip joint. And there are two main conditions that lead to hip preservation surgery. That's hip impingement, where we have abnormal contact between the ball and the socket. So the hip is a ball and socket joint. And when we have abnormal contact around the rim of the socket with the ball, that's called hip impingement. Hip dysplasia is most commonly a condition where we have a shallow hip socket. So the hip is actually unstable. And in that condition, if we do surgery, we reposition the hip socket. So those are more pre-arthritic hip conditions, hip impingement and hip dysplasia. They tend to present in younger patients. And in those patients, we consider hip preservation surgery. You know, interestingly, those conditions, the hip impingement and hip dysplasia, are the most common reasons that patients get hip arthritis over time, over their lifetime. So for example, a patient that has hip dysplasia may not present until 60 years of age when they have end-stage arthritis of the hip. And that's when we consider hip replacement. So that's the distinction between hip preservation and hip replacement surgery.
What are some of the conditions that lead to each type of intervention?
Yeah, so that's just a follow-up on those conditions. So for the hip preservation procedures, hip impingement is common. That's commonly seen in active young patients. The average age in our practice of hip impingement patients is about 25 years of age. They tend to be active, healthy patients. And again, they present with discomfort in the groin, activity limiting pain in the hip. Hip impingement is most commonly treated with hip arthroscopy. So that's a minimally invasive procedure where we make small incisions about the hip. We're able to access the hip joint. We can repair cartilage, we can repair the labrum in the hip joint, and we can reshape the bone to relieve the hip impingement. So that's hip impingement disease, very briefly, treated with arthroscopy. The more complex hip impingement problems can be treated with open hip surgery. So if we have a very severe hip impingement problem, we can use open surgery to treat those problems. And in our practice, that's about 10% of the patients. Otherwise, they get treated with hip arthroscopy. Hip dysplasia, again, is the shallow hip socket. That can also lead to pain and limited function in young patients. And in that young patient population, the most common procedure for hip dysplasia is a periacetabular osteotomy, or PAO. So PAO means cutting the bones around the hip socket and repositioning the hip socket. So that's the most common procedure we perform to treat hip dysplasia. And again, that's in the young patient. Hip arthritis, as I mentioned, hip impingement and hip dysplasia lead to hip arthritis over time. And as we get advanced hip arthritis, optimal treatment for those patients is a hip replacement, which pretty much everyone has heard about or has known someone that has had a hip replacement. So those are kind of the three types of patients: hip impingement, hip dysplasia, and then hip arthritis patients.
How long would you say that it takes people, or I'm sorry, how long do people stay in the hospital?
So it really depends on the procedure. So if we're talking about hip arthroscopy, that's a same-day surgery. So all of those patients go home the same day. They tend to be on crutches for a short period of time and progressively increase their activity. The PAO, which is the surgery to correct hip dysplasia, those patients are in the hospital usually 2 nights. You know, occasionally we have a patient that's just in the hospital 1 night, occasionally 3 nights, but usually they're in the hospital for the day of surgery and then 2 additional nights in the hospital. That's a bigger procedure. We do cut the bones around the hip socket, reposition the hip socket. So that's a little more involved than the hip arthroscopy. And then we have hip replacement. So hip replacement, you know, that procedure and the recovery has markedly changed over the past several years. Patients used to be in the hospital 3, 4, 5 days. And now a lot of our hip replacement patients actually go home the same day. So we have a rapid recovery program. And if, especially for patients that are a little younger, they're healthy, we get them up and going and home the same day. So we do same day hip replacement for a lot of our patients. For the elderly patient population that may not be as healthy or as active, that need a little more care and a little more therapy, we'll keep them in the hospital overnight. And then usually those patients will go home the next day. So tend to be short hospital stays for all the procedures or even outpatient procedures.
And then on these procedures, what do you think, or what is the time that it takes for a full recovery from
Yeah,
both of these?
so full recovery depends upon the procedure. Um, the we do see a lot of improvement pretty quickly in the hip replacement procedure. So a patient really, after 2 or 3 days, the hip may feel better than it did before surgery. But in terms of full recovery, that really takes quite a while. I would say for most patients, that's about 3 months or so before the hip really starts to feel good. The stiffness is gone, the muscles are strengthened, and the patient is back to near full activity. So for a hip replacement, it's about 3 months. It also takes a while for the body to recover from surgery. So most of the recovery is seen within that first 3 months. But in a lot of patients, their outcome at a year is even better than it was at 3 months. So they tend to slowly improve over time. The hip preservation procedures are similar in that it takes about 3 months really for the joint to recover, the muscles to be rehabilitated, and the patient to return to their full activity. So 3 to 4 months, and then we also see a little improvement after that.
We actually have a question from the audience. At what point would you recommend a replacement versus PAO for a patient with hip dysplasia? Is there a pivotal age?
That's a great question. And actually, there are a lot of patients that present to us with that circumstance. So when a patient is, let's say, 20 years of age and they have hip dysplasia, that's a pretty easy decision. They're usually best suited for a PAO surgery. If a patient is 60 years of age and they have hip dysplasia and they have some arthritis, then that patient is best suited for a hip replacement. Where it's a little unclear is in that intermediate age group. So that's usually between 35 and 50 years of age, and the patient has hip dysplasia. So theoretically, they're a candidate for a PAO. They may have arthritis in the joint. So at that stage, we're also starting to think about hip replacement. So it's really multiple factors that help us make that decision. So if it's a patient in that 35 to 50 group and they have a healthy hip joint and they're a healthy active person, then we would think about the PAO. If it's a patient in that same group, but they're starting to get arthritis or they have other issues that might impact the outcome of PAO surgery, then we think more about a hip replacement. But that's a perfect example of where that patient really needs to be evaluated by a physician or a team of physicians who know all the different options and know the different indications for those different procedures.
Great. Also seeing some comments in the some comments being made that you did my daughter's PAO in this day, first one, and then the second one on a different year. How common is that once you do any of these procedures that you have to go back and do the other on the
Yeah,
other hip?
yeah, that's a great question, and that's actually a question that a lot of patients ask us that. So we've actually done studies to determine those numbers. So we have two publications and then a couple other publications that are coming out in the near future, and looking at the other hip in a patient that has had one hip with surgery. And the bottom line take-home message is, at 5 years after the first hip, about 50% of patients have gone on to have the second hip done. So with hip impingement and hip dysplasia, It's very common that the other hip is also involved. And again, 5 years after the first surgery, half of the patients have gone on to have surgery on the other hip. And that it brings up another important point, and that is following the other hip is very important. So if a patient has impingement or dysplasia on one side, we're going to carefully follow the other hip over time.
Is there anything else that you feel that our viewers should know about the surgery to help with hip problems? Anything to look for?
I think in general, the treatment of hip disease has really changed remarkably over the past several years. And there's a lot of new information, and there are new surgical techniques. I think really important is that people realize it can be a complicated, like the question on the PAO versus total hip, it can be complicated, and it can be somewhat challenging to sort out the most accurate diagnosis. And then it can be challenging to provide the best surgical treatment for each patient. So really, it takes experienced physician or team of providers to provide, comprehensive care to the hip. So like in our group, we have several providers, we have several surgeons that come from different perspectives, from pediatrics, from sports, from adult reconstruction. We work with our physiatry group. We work with our physical therapists very closely, really to arrive at an accurate diagnosis, treat the patient non-surgically first. I think that's very important because a lot of patients will get better with non-surgical treatment. And then if the patient fails that, we think about surgery. And we really have a full armamentarium of surgical procedures to apply in a very patient-specific manner. So I think seeking out real, true experts in the field is really important to optimize patient care and to get great care or get great care for your family member or friend.
We have another question. With young female athletes who turn in or have a asymmetrical leg positioning and standing, is there anything that can be done to prevent progression of hip impingement, or is it something they are born with and it's a waiting game?
So that is a great question. It's a difficult question. The female athlete has a lot of different potential problems with the hip. So that's something that, there's no one answer, but if that patient were to have, or person were to have hip pain, that would take close evaluation to, number one, come up with a diagnosis, and then number two, come up with the best treatment plan. But in general, a young female patient that has, I think you said turning in or in-toeing, is that correct?
Mm-hmm.
In-toeing of one of the limbs or both of the limbs, that's usually an indicator of hip dysplasia. Okay, so the limb may turn in to stabilize the hip. That turns the ball into the hip socket and makes it a more stable joint. So the patient may be doing that to protect the hip joint. The other reason we see that is just rotation of the femur bone. So the patient may just have abnormal rotation of the femur, which is a form of hip dysplasia, and that's why that limb turns in. So most common diagnosis would be hip dysplasia. If that patient has hip pain or the turning in is severe and problematic, then that should be evaluated by a specialist.
We have another question. Have you done any research with Charcot-Marie tooth and hip dysplasia? Sorry.
Yeah, Charcot-Marie tooth disease is a challenging neuromuscular disease. We do see patients with hip dysplasia with CMT. We could also call it CMT. And we have done a lot of patients, we've done surgery to treat their hip dysplasia. The concepts are the same in that they have hip dysplasia. They tend to also have very lax soft tissues. So in addition to the bony abnormalities of the pelvis, they also have soft tissues. So treating their hip dysplasia can be very challenging. The PAO surgery, which we do, is the mainstay treatment for those patients. And that can be very helpful for patients with CMT. Sometimes in those patients, we also have to correct the femur bone. So in one surgery, we'll correct the socket and the femur bone. And that can be very helpful for those patients. They are challenging. So the outcomes are good, but they're not quite as good as other patients with hip dysplasia that don't have an underlying issue like CMT. But certainly we do those procedures and they're helpful for the majority of patients.
How common is hip dysplasia in families, as far as I guess hereditary?
Yeah, so there's a strong family predilection for hip dysplasia, especially so hip dysplasia is seen in 80% of the cases are in females, and a firstborn female is at the highest risk to have hip dysplasia. So certainly if there's a history of hip dysplasia in the family, then the family wants to be aware of that. And in that family, if there's any hip pain, like we've talked about, then that should be evaluated readily to make sure we don't miss a diagnosis of hip dysplasia. It certainly does run in families.
Hmm? Is there anything else you'd like to add, or is there any other questions from the audience? We would like to take them now, but is there anything that you would like to add, Dr. Clohisy?
No, I think it's an exciting time in the treatment of hip disease. We've learned a lot over the last several years. Hip replacement surgeries are becoming better and better. Our group has introduced minimally invasive techniques, including the mini posterior technique, the anterior technique for hip replacement, and rapid recovery. So, that's an operation that is extremely successful for the vast majority of patients. And then the other procedures, the hip impingement and the hip dysplasia procedures, have advanced tremendously over the past decade. And in the past, like the PAO was considered to be a very big operation, dangerous operation, and that has evolved tremendously. So we do that surgery all the time. I think we've done 6 PAOs this week, and the patients are up out of bed the same day, and it has really improved. So just a comment that the treatment of these conditions has markedly improved and will continue to do so as we move forward.
And we have one question. More and more folks, especially runners, are having hip arthroscopy for labral tears. Is research showing that the surgery helps, or does it just increase the chance of a THR?
Yeah, so it depends. So certainly hip arthroscopy has become very common. The most important thing about that, so runners can be challenging to treat. I think the general answer to that question is, with an accurate diagnosis and an appropriate hip arthroscopy, the majority of athletes or runners will improve and get better from surgery. But it brings up a very important point, and that is that hip impingement can be seen in runners. And if it's a kind of relatively normal pattern of hip impingement, that can be treated with the hip arthroscopy. We repair the cartilage and then we shave down the bones to relieve the impingement area. So that can be very successful. The other condition that we see in runners is hip dysplasia. Now, hip dysplasia, as we've discussed, is a shallow hip socket, and that can lead to a labral tear. But that's a hip problem that we don't want to just treat with hip arthroscopy, because if we just repair the labrum and we leave the hip dysplasia there, then that patient is at high risk to fail and go on to need additional surgery. So it's very important that a correct diagnosis is made. And if there's a diagnosis of hip dysplasia, that is best treated with the PAO. Sometimes we combine the PAO with hip arthroscopy, but the PAO surgery is really what's most important in terms of correcting the instability so that patient can return to their activities, even activities like running.
Is there, after a hip replacement, are there any restrictions in hip exercises?
So it depends. So that's going to be dependent upon the surgeon and the specific patient. In general, Um, you know, in my practice, I've gotten to the point where I really don't restrict patients from activity except a couple things. So, for example, long distance running, I'm not too enthusiastic about that on a prosthetic hip joint. So I would prefer if a patient really wants to run, that we do that in moderation, you know, maybe 2 to 4 miles 3 times a week or something like that. And then the other thing that I would not like is in a younger, healthy person to be doing, you know, really strenuous exercise like deep squats with a lot of weight, that kind of thing. But besides that, I pretty much let my patients hopefully return to the activities that they desired and did prior to their hip replacement.
Um, can both hips be replaced at the same time?
That yes, they can. Um, so that would be, for me, I haven't done that. I prefer to do one hip at a time. Certainly they can technically be done together, but both with hips and knees, the complication rate and the serious complications is a little higher if both procedures are done at the same time. So given that little bit increased risk, I prefer to do the procedures one at a time.
Mhm. Well, that we are about out of time, and there's doesn't seem to be any more questions. Again, thank you so much for joining us today. Would you like to share where your clinics are located and where you see patients at?
Sure. So I'm chief of the adult recon service at Washington University, the School of Medicine Department of Orthopedics. We have several clinics. We have clinics down on the main uh, BJH campus. We have clinics out at Barnesworth County. We have clinics in the Orthopedic Center in Chesterfield in South County. And now we've started a clinic out at Progress West. So we really have a lot of sites around the town, and enjoy taking care of all the patients from different areas of the region.
Well, thank you so much. Hope everybody enjoyed us and enjoyed today's discussion, and we'll see you on our next Facebook
Thanks,
Live discussion.
Crystal. Okay.
Thank you.